All right, so once again, a fairly dense talk on this one in terms of the medical and surgical management of acute pancreatitis. So we'll go through the demographics, epidemiology, and clinical presentation of this, laboratory features, scoring systems, and then we'll review the management principles in terms of fluids, nutrition, antibiotics, ERCP, and interventions. A lot of good recent studies that will undoubtedly be queried on your exams, and what happens to these patients. So which of the following patients is most likely to have gallstone pancreatitis? The 25-year-old male with multiple previous admissions for abdominal pain and an amylase of 78. The 55-year-old female with renal failure, abdominal pain, and an amylase of 600. The 60-year-old female with abdominal pain and an amylase of 1100, or a 35-year-old male with abdominal pain and an amylase of 85 and a lipase of 425. Okay, and this is the appropriate age range for gallstone pancreatitis, female, a little bit older than men, and she doesn't have renal failure, so you can rely on her elevated amylase. We'll talk about that shortly. A fairly common disease. The etiology is going to vary depending on where you are. Remember that it's only the very tip of the iceberg of these patients that see us in the ICU. The proportion that are coming to the ICU perhaps increasing in incidence, and women generally present later, once again, because of the etiology of their disease. More or less, and certainly it's going to vary depending on your practice and where you are, a third gallstone, a third alcohol, and a third other. And the reminder of the third other is that even those patients often have little tiny stones, and the question there is, would removing the gallbladder help out the pancreatitis ultimately? Acute onset of upper abdominal pain with signs of sepsis and infection, and certainly the severe acute pancreatitic appears toxic. Remember the retroperitoneal hemorrhage that can occur as a result of this, and that is manifested by the Cullen sign, which is the hematomas around the umbilicus, and then the Gray-Turner sign that you see, which is blood along the flanks, or bruising along the flanks. So what are the patients we see? Who has severe acute pancreatitis? So those are patients with pancreatitis and organ failure, complications, and have some components of an elevated score, whether that scoring system be the old-fashioned Ranson or Apache. Why is this important? These are the patients who should come to the ICU, be monitored, and appropriately resuscitated. And once again, remember, it is the very tip of the iceberg. So for every 10 patients that come into an emergency department with pancreatitis, this is 1 or 2 patients. Amylase, in the absence of renal failure, should be elevated. This is a sensitive and even more specific exam, and remember that lipase has a longer half-life. Certainly C-reactive protein and procalcitonin can be elevated, but as sure as other speakers have talked about procalcitonin, probably a lot more helpful in minimizing therapy in the back end of your treatment rather than in the diagnosis mode. So, not generally very helpful. These are very old, certainly the Ranson criteria. And remember, basically, there are some demographic features or features at presentation that cause, or at least made Ranson think that your pancreatitis would be worse. And then all the lower features, which were noted at 48 hours, were relative to the need for resuscitation. In his day and determination, the more criteria you have, the greater your chance of mortality. But the reality is, for those lower scores, they really weren't very predictive of the severity of this. And in fact, what performs better are general scoring systems, Apache 2, 3, 4, or just general assays of your organ failure system. The reality is most patients that come to you are going to have a CT scan, but in truth, these are patients who are in shock, who are going to be at a high risk for renal failure, and to make this diagnosis, you're going to be giving the patient intravenous contrast by CT scan, So if it were up to you, and it's not going to change your management, and early on it likely doesn't change your management, it would be nice to not do a CT scan for 72 hours until you're done, or at least you're done with the initial phase of resuscitation. But in reality, we all know that these patients are going to present to us from the emergency departments and have their tag on them and have the CT scan. Just remember, you're going to have to resuscitate, that contrast load on the patients as well. Now, once you do get a CT scan, realize that there are findings on it and scoring systems, once again, that say the more abnormalities in the pancreas and the more extrapancreatic abnormalities in terms of fluid collections, the worse you are, so that you get points based on your CT scan grading and your risk of necrosis, and certainly your risk of developing severe pancreatitis and its complications increases as your score gets worse. So as you see, the higher scores, the highest score, they will all get complications, and the death rate is significantly higher than it is for others. There are some other modified scoring systems out there that, in addition to the pancreatic and intra-abdominal and local complications, also add points to, for example, pleural effusions and other findings. This was the initial attempt at some sort of scoring system and using, or not scoring system, or classification, I should say, using different words and terminologies. And this was the Atlanta system. We'll talk about its updates in a bit. I would point you to two, which we'll hit in a few slides, is the concept of pancreatic necrosis, right? So there's dead tissue in the pancreas fueling this process. And remember, pancreatic necrosis doesn't necessarily mean infection. That's going to be an important part of this. And once again, they attempted a scoring system based on these findings. And with all of them, once you infect the necrosis, your risk of complications are going to increase. So here's an image example of what I'm talking about. The image on your right shows a pancreas that is not lighting up with contrast. So you start to see contrast in the kidneys, a little bit in the spleen, not as much in the liver, but the pancreas is certainly not of the same CT density, and that's because it's dead. And this is going to change. If you have this image, that's going to, without any other data, that will bias what you're going to do. We'll talk about this shortly. On the other hand, the CT scan on the left is far more ominous. You actually see air around the pancreas, so that pancreas is not just infected, it is not just necrotic, it's infected. So there's a thought that since if you actually carve out, based on Atlanta, the criteria into mild, moderate, and severe, that severe is definitely worse, that there was a need or a thought to need to revise the Atlanta classification, and here it is basically. Once you develop organ failure with this, you're in a different class, you have higher mortality, higher morbidity, and we ought to be thinking of these patients differently. So that's, once again, they now use these terms. So the interstitial edematous pancreatitis, which is, what people come into the emergency department with, they either have necrosis or not, they either have fluid collections and or not, and then ultimately these develop pseudocysts. And yet another scoring system for you to sort of take a look at. So I think I've sort of tortured that beyond belief. Why don't we go on to how you're going to manage these patients in here. So this is a 60-year-old woman presents to the emergency department, new onset pancreatitis, amylase 4,000, yeah, it's the real deal, white count of 16, glucose of 210, calcium of 7. So sort of think about that in terms of Ranson's. The best management would be, do you admit her to the hospital? Do you admit her to the ICU? And what's your imaging modality? And what are your other adjuncts? Okay, and not just because I'm an ultrasound geek, but the point here is this is clearly someone who has Ranson's criteria on admission. She is going to get sick because of her age. She's going to require monitoring and observation, so an ICU is going to be appropriate. It would be nice if you had a choice to not image her with a CT scan, because that's not going to change your management early. You can figure this out with an ultrasound. I recognize in the real world she's going to come to you with a CT scan that you're going to have to resuscitate further. So that's why that's the appropriate answer. So, you know, eyeball imaging and scoring system to see who's at risk, then you monitor them, and who's going to get sick, elderly, obese, and then substantial necrosis when you get to sort of figuring it out. What is the dysfunction that is going to trend how sick they are? Well, it's like with all the rest of your ICU patients, right? If their lungs get really sick and they get on the ventilator, well, that's going to bias who and where and how they turn out. And despite incredibly large volume resuscitations, these patients certainly can develop renal dysfunction and require replacement therapy. Now, how should we manage the fluids in these patients? Interestingly, the data is not as robust as you imagine would be. So this is a very nice sort of analysis of this. Over 400 studies, only 15 really met inclusion criteria for how you should resuscitate your pancreatitic patients. Only 2 of these were randomized controlled trials, most very low quality. And interesting, whether you should be aggressive or restrictive, the data is on either side. The bottom line is you should be appropriate with your resuscitation, but certainly by giving these patients a lot of fluid, you're not necessarily going to make things better. Nutrition, different story. I think there's a lot more robust data here. Some of it was alluded to in the prior talk, and I'll sort of highlight it in terms of the pancreatitic patients. So what is the appropriate nutritional management of a patient with acute pancreatitis? Number 1, strict NPO until the amylase normalizes. TPN, full caloric that way. Trickle tube bleeds and supplement with TPN or enteral nutrition. Okay, wonderful. And you know, answer 1 was, you know, what we did when the gray hairs, they're artfully disguised, don't belie. There's actually going to be a different option in there too, which comes from a couple recent studies. That's fascinating. So it is appropriate to enterally provide this for patients. Why is that? Well, we're not having this discussion in patients who have mild acute pancreatitis. Frankly, if you want to put someone who's not that sick NPO for 7 days, it's really not going to change their outcome. So you can do whatever you want in the patients who are on the floor. However, the real change in management is going to be for those patients with severe acute pancreatitis who come to you. And in fact, enteral nutrition is preferred. Why? Decreased length of stay. It actually resolves your systemic inflammatory response syndrome more appropriately. It decreases your infection rate. It actually makes the ileus resolve. It does not stimulate exocrine secretion to a great extent. Optimally, within 72 hours is when you start this. Many randomized controlled trials studied, and sure enough, associated with fewer infections, decreased length of stay, a trend at least, whatever that means, towards less organ failure with no effect on mortality. And you really shouldn't sort of hit pull the trigger quickly for parenteral nutrition. This is what Cochrane has to say about it. 8 trials, 348 patients. So enteral nutrition favors for all in terms of death and all the other parameters. And for severe acute pancreatitis, in fact, a real profound change on the death and multi-organ failure rates. Now, in the last year, and this is well beyond, I believe, what's going to be tested on any of your boards this year, but just very fascinating and interesting for you all. Several studies have shown that in patients and severe acute pancreatitis, not just people who aren't that sick, it is actually possible to, and it doesn't worsen outcome in terms of length of stay and complications, to actually feed these patients real food. Now, obviously, if they're ventilated, and on the ventilator, this isn't the conversation, but once you've gotten them extubated, it's actually possible to feed patients, and you're not going to cause that much harm. And how do you guide this? Well, if the patient's hungry, let them eat. Now, I will acknowledge it's probably a little bit too out there for the boards, but we've come full circle from, starve them, put them on TPN, to now maybe it's not so bad to just let them eat whatever they want to eat. Okay, now the next, hopefully not controversy, is what do you do with a patient with severe acute pancreatitis, febrile, white count of 20,000. Which antibiotic should you use? Good, and certainly we'll talk about why imipenem isn't the right answer. None of the above, and I will give you the asterisk, because who needs to be treated? So there was certainly early work to decrease use of antibiotics to decrease the risk of infection and death. Very flawed studies early on. And in fact, what often happens when you provide such aggressive antibiotics to these patients is that you select for resistant organisms, you select mostly for fungal organisms, and the patients ultimately die of sepsis from these. So you can see that if you break down the studies just in terms of early studies, later studies, it's really the earlier studies that seem to suggest that antibiotics were beneficial. This is Dellinger's multi-center prospective trial, very well done, looking at 100 patients randomized to Marum versus placebo, and it did not support the use of antibiotic prophylaxis. And here's what Cochrane says on it. So it's 2010 review. They actually have altered what they said in 2006, 7 trials, 400 patients, that prophylactic antibiotics do not alter your death rate, that they don't change your proportion of those patients developing infected pancreatic necrosis. However, to hedge its bets, it said, well, maybe we need to sort of do further studies. But at least in 2010, Cochrane said you don't need antibiotics for pancreatic necrosis, and prophylaxis, right? So who gets antibiotics? So this shouldn't say prophylactic antibiotics on top right. Who gets antibiotics in patients with pancreatitis? Well, if you put a needle in the necrosis and you get back a culture that's positive, well, certainly culture-proven infection merits antibiotics. And yes, imipenem is, at least in studies, not an unreasonable choice. The CT scan I showed you of the patient with pancreatic necrosis and air in that collection, the air dots in there, pancreatic gas, there are organisms causing that. They are infected by definition. They require it. And, you can hedge your bets with you really think they're infected while that needle's going in and before the culture comes back. That certainly is your hedging of the bet. But in general, not for prophylaxis, for patients who you think have infections. What about the role of ERCP, right? Oh my gosh, we shouldn't put an ERCP scope near someone with active pancreatitis. The indications are those in whom you suspect the cause of their pancreatitis is obstructive jaundice and or cholangitis, not just a patient with acute pancreatitis who happens to have gallstones. If you wish to determine whether or not the stone is still in the duct causing obstructions, it's certainly not unreasonable to perform an endoscopic ultrasound first to determine whether or not your ultimate ERCP is going to be therapeutic. So you can hedge your bets that way. So 7 randomized trials of ERCP versus control. Interestingly, in this study, no difference in many of the parameters. And also, once again, another study which suggests that, maybe ERCP, even for obstructive jaundice, doesn't change large overall outcomes. But once again, Cochrane reviewed these studies in 2012, 5 randomized controlled trials. In addition, looked at 2 with severe gallstone pancreatitis. And they noted a benefit in mortality, local and systemic complications in those who had those with cholangitis. So it is not contraindicated. In fact, it is indicated to perform an ERCP in patients who have pancreatitis from obstructive reasons. Now, what do you do with the gallbladder, right? Once you've determined that your pancreatitis was due to gallstone pancreatitis, when do you take that gallbladder out? The literature is not horribly helpful here at times because often the patients with severe acute pancreatitis are removed from this, so we're talking about patients that are less sick. However, note this, about 20% of these patients will develop not just symptoms related to the gallbladder, which they definitely will, but 20% will develop recurrent pancreatitis. And the gallstones as well will have symptomatology. And generally it occurs pretty quickly after discharge. So I think the practice pattern is generally that you wait until the resuscitation over, the patient's stable, and before they go home the gallbladder comes out. So you probably should not discharge your patients until that's happened. Okay. Now back to sort of the surgical aspects of this, and I think this is probably fair game for the non-surgical boards as well. A patient with severe acute pancreatitis and infected necrosis should undergo, number 1, open surgery, number 2, percutaneous drainage, number 3, percutaneous drainage with additional minimally invasive drainage is needed, or 4, just keep them on antibiotics. Okay, good. And once again, this is the step-up approach, which we'll talk to in future slides. You really would love to not be in number 1 land. So why in general do we operate on patients with acute pancreatitis? Well, early on, maybe you walked your way into there, the patients are sick, they have peritonitis, you're on a go look-see. We don't do this very often, and you happen to stumble upon it. Or if they're fulminant and infected. Early, it's not unreasonable to have to operate on someone with abdominal compartment syndrome. And then later, it's not uncommon to have to do something about a pseudocyst. And in the middle range, certainly the complications drive your need for this. This general concept sort of derived mostly in Europe, but the thought is that you can sit on sterile necrosis. Anything you do to sterile necrosis is not going to benefit the patient. Now, at some point, you may need to do something, particularly if there are obstructive symptoms of this. So the only way you can figure out in someone who's just not getting better whether that necrosis is infected or not is to put a needle in this, do a fine needle aspiration, or if you're lucky enough to see the CT. And then if you prove infection, then you go ahead and do something. So here's the something. Once again, as I said, often you end up doing early, not often, you may end up in early surgery if you've basically blown the diagnosis or there's some complication of it like bleeding or bowel obstruction. But this is a surgery fraught with very high complications and a substantial bleeding risk, and in old studies a significant mortality rate. So what we used to do, these awful open abdomens with takebacks and takebacks didn't benefit the patient. With better imaging studies, better resuscitation, we're generally not here much anymore. What were the options? Well, you pack them, you did repeated laparotomies, or there was all sorts of fancy ways of sort of not having to go back to the operating room all the time, closed placking and drainage lavage, and then, to sort of intentionally sort of start out with minimally invasive methods. I'll get back to those in a minute. The more procedures you did, it was just a greater chance of screwing things up, basically. The more times you were in there, the greater your chance you were going to poke a hole in the bowel, cause a fistula, hemorrhage, and certainly you were going to get hernia and loss of domain. So this is no longer, at the top of your algorithm. And, once again, these are some drawings and schematics of, what the lesser open surgeries were. So let's talk about some of these minimally invasive techniques that underlie the step-up technique. There's just put a drain in it. Oh my gosh, you sort of thought about it. Why would we want to do that? We'll leave a fistula for sure. There's laparoscopic resections of these, so retroperitoneal things. There's the step-up approach, and then we'll end with penguin or the thoughts of transgastric debridements. So this is the studies underlying the basis for doing the step-up groups. Many studies looked at this, and often you can get away with just putting a drain in these patients and not doing anything further. And if you look at these studies, in fact, these were very sick patients. So it wasn't like they were just carving out the patients who were well and were going to go home anyway. But sometimes all you need is just to put a drain in, and they're going to do fine. So a nice analysis of doing a minimally invasive retroperitoneal necrosectomy versus opening them up. And the bottom line is that, once again, if you have to go in there surgically and do something, it is nice if you have the capability of doing this through a minimally invasive approach in terms of reductions of complications and mortality. So this is the step-up article, now several years old, a multi-center randomized trial of patients. So the thought was that you started off with a percutaneous drainage. If that's all they needed, that was great. If they weren't getting better, you would put these scopes in retroperitoneally as opposed to open, and you would look at complications and mortality. And sure enough, as to patients who had their necrotic infected pancreas opened up primarily, much lower risk of complications, multiple organ failure, and death. So this was a real revolutionary and a win. So it's certainly less costly. And remember, in a good chunk of the time, you can get away with just sticking the drains in. Well, if less is more, then maybe even less is even more. So this is the transgastric approach, or the notes, or the penguin, where an endoscopist will go into the stomach, punch a hole in the back wall of the stomach to sort of get at all these things. And surprisingly, there's actually a lower fistula rate in this group than in other methods. It's definitely ready for prime time. I wouldn't say that it's beyond the boards in terms of asking and querying this. However, there's not a ton of data on a lot of patients in terms of which is better, to put a laparoscope in someone and do it if percutaneous drainage fails, or putting a gastroscope in and doing this. And I think beyond discussing this is probably well out of the realm of any of these, even the surgical boards. I think this is probably all you would see on it. All right, some other complications: abdominal hypertension and severe acute pancreatitis. Number 1, invariably associated with compartment syndrome. 2, managed via decompressive laparotomy. 3, common, thus surveillance should be done. Or 4, managed with an NG tube decompression and diuresis. Okay, wonderful. So a very common, but it doesn't mandate opening all of them, okay, unlike in other situations. We'll get back to that shortly. So what happens to these patients? Well, certainly they develop shock from hypovolemia and from vasodilatory shock. The most serious and common side effect of this is respiratory failure and the need for ventilatory support. Despite adequate resuscitation, in the face of doing that CT scan with contrast, they may develop renal failure and certainly downstream infectious complications. Abdominal-related complications, GI tract obstructions and bleeding can occur, which may drive you to surgery. They may evolve into abscesses and pseudocysts, which will require further treatment. And there may be interventions required beyond the original pancreatitis because of bleeding and things. Now let's talk about abdominal hypertension a little bit. Incredibly common in anyone who you're going to do a large resuscitation on, right? I mean, the first time you started really aggressively doing early goal-directed therapy for pneumonia patients, suddenly you were giving your patients abdominal compartment syndrome as well. The sicker the patients, the more fluid you give them, obviously, the greater the chance of developing abdominal compartment syndrome or hypertension. It can progress to syndrome, although the full-on syndrome is a lot less common, about 20% of studies, patients. So the bottom line is you have to look for it. So you have to measure bladder pressures. However, it doesn't necessarily mean that once you find it, you have to open them up. It may be possible to just put percutaneous catheters in these patients and drain them percutaneously and do all the other things short of opening up the abdomen. This is probably the perfect patient population to consider in, as opposed to abdominal compartment syndrome, for example, in a post-op trauma patient. So the greater your organ failures, the greater your chance you're going to have mortality. What do you die of earlier? Well, you certainly in both instances can die of organ failure, but later on the local complications start sort of hitting it as well. So in conclusion, who's going to be at risk? Who needs your ICU? Important to realize that this is only the tip of the iceberg to send them in there. Aggressively monitor and reassess them. Early enteral nutrition appropriate for most all patients. However, we're probably going to evolve to the point where if you're not intubated, you can just eat food. Antibiotic prophylaxis not indicated. Certainly therapy warranted once you prove you have infected necrosis, which you may do with a sample or those air bubbles on a CT scan. ERCP appropriate for obstructive jaundice and cholangitis. If you have a patient whose pancreatitis is due to gallstone pancreatitis, which is about a third in most series, take the gallbladder out that day once they're stabilized. For a fulminant course, you may end up with early intervention, and otherwise your late interventions are for infected, secondary infections or failure to improve. Open surgery, we've hopefully come away from most of that, and step-up approach, probably the most appropriate, although transgastric drainage may be appropriate in other patients. And finally, remember that intra-abdominal pressure monitoring should occur in most of these patients, and you may need to do something about it, and hopefully it's not surgery. Thank you.